Yeah, so we are live. Hi, everyone, and welcome to Charity Safe Haven. This is a special segment on my platform. We are not the Nutritionist Corner. We are Charity Safe Haven, and my name is Charity Wanyonyi. I'm the co-founder. I'm the founder, Kimazoya. I'm the founder of Charity Safe Haven, and today I'm joined in by for nutrition students. Like I had advertised, we're going to talk about attachment experience. We have one more guest who is going to join in later. Oh, there she is. Oh, Lillian, I can see you. So at least she has joined us. So we are 6 of us. So we're going to start. And I'm going to let you guys introduce yourself. I don't know how we are going to start. Do we do ladies first? Millicent, you can start introducing yourself and tell us where you are attached. Currently, if you've been assessed, how is the experience? How are you, so that people can get to know you?
Yes. Hi, Charity, and hi, everyone. So, my name is Millicent Kagendo.
Millicent, we can't hear you. Is it my network?
Can you hear me now?
Yes, we can hear you.
Yes. My name is Millicent Kagendo, and currently I'm not attached anywhere. I was at the University of Nairobi, saizi nangoja graduation. Yeah, but my attachment journey has been anything but predictable. So, yeah, I'm happy to be here having this conversation today. Yeah,
Thank you so much, Millicent.
you're
Arnold, you can
welcome.
take over. You can introduce yourself and tell us where you're attached, how is the experience.
Okay, hello everyone. I'm Stephen Arnold. I'm the treasurer, Cancer. I'm also a nutritionist student at Kenyatta University, my final year. I've done my clinical attachment already last year at Kiambu level 5. And then at the moment, I'm working with an NGO, a Canadian NGO called Farmers Helping Farmers. It's in Meru County. This is what it looks like. Yeah. Yeah, so that's it. I'm really happy to be here. Really nice to meet you all. Thank you.
Thank you so much, Arnold. I wish we would have seen it because hii video imetulet down kidogo. Yeah, so Sylvia, you can introduce yourself and tell us where you're attached currently.
Okay, so hi everyone. My name is Sylvia Anami. I am the new vice president of cancer, and I'm also a nutrition student at Kenyatta University. Currently, I'm attached at Pumwani Maternity Hospital. It's the best maternity hospital actually in Kenya, and they deliver so many mothers per day. So yeah, I'm happy to be here, and I hope that I will encourage someone with by me sharing my experiences on this attachment, and I'm also hoping to have fun while I share. Thank you.
Thank you so much, Sylvia. She's the vice president of the Student Association, and Arnold is the treasurer. I don't know if you had said that. Sharon, you can introduce yourself and tell us where you're attached.
Hello everyone, I'm Sharon Ore. I'm a nutrition student. I just completed my coursework. Last year I did my clinical attachment at MPSHA, and I've done also a clinical attachment at NTRH. Currently I'm working with MDA Studios as a nutritionist, and yes, also volunteering with NTRH. So yeah, that's what I'm doing, and I'm looking forward to this discussion. Thank you.
Thank you so much, Sharon. And finally, Lillian. When you mwenyeji hapa, you can introduce yourself. I don't know if you're comfortable to show us who you are.
Good evening, everyone. I'm going to turn on my mic, my camera in a few. So please accord me like 2 more minutes. So, hello? Charity?
Yes, we can hear you, Lillian.
Oh, good. So my name is Lillian Momina. I'm a registered and licensed clinical nutritionist. I have gone through the whole process of training, practicum, attachments, internship, volunteerism. So, and I'm definitely glad to be here tonight to be sharing some of the sentiments, some of the experiences that we went through, so that you don't have to go through, and definitely how to maneuver them. So I am definitely glad to be here.
Thank you so much, Lillian. Sisi wenye tulimaliza attachment na internship kitambo huko hata tukumbuke. Anyways, thank you so much for that introduction. And I'm very happy you guys honored my invitation to come and feature, because I've had this idea for a while and actually didn't know how to execute it. But thank you so much for coming along. So we're going to start with the first question, and we're going to look at the expectation versus reality. So I don't know, I think we'll start how we appear on the screen. So Arnold, you tell us, what were your expectations going into the attachments? You're done. So back then, what were your expectations going to the attachment, and how was the reality when you got there and you're like, wow, this is not what I had expected, or more good? So feel free. Arnold can start, and then Sharon, Millicent, Sylvia, and then Lillian. Thank you.
Okay, thank you, Charity. Well, I don't know what happened to ladies first, but I'll take the podium. Anyways, yeah, so um, I'm Stephen Arnold once again, and I've done, this is my second attachment. I've done clinical attachment, and right now I'm doing my practical community attachment. So I have both expectations. So when I was going into the clinical, I don't know, I expected a structured, book-oriented type of environment, but then I got to understand that I don't know, the classwork and the whatever we learned in school. I think this is for the first time I appreciated, or rather, I saw the importance of learning UCU in first year. You know, the critical thinking and what was it? The UC 110 and 111. Yeah. So I think this is the first time that I appreciated why we learned the two units. So I think my expectation was I'm going into a structured book environment area. So I'm going to be questions, answers, what I have crammed in my mind. But then when I got into the ground, I saw that there's a lot of critical thinking aspects compared to what is in the book. Because you find an example of during my attachment at my clinical attachment, you find a patient has diabetes and hypertension, and you probably kidney AKI, acute kidney injury. So these are things that if you manage one, it can affect the other things. So you have to have a lot of critical thinking in mind. So I think my expectation was whatever from Kenyatta University, whatever Dr. Nyamoto had taught me in my NCP or in my disease management is what I'm going to translate to the environment. But then I go to see that I need to be open-minded. I need to have a critical thinking. I need to be resilient in order to work in this capacity. So, yeah, that was it. And then during my second attachment, which I'm currently under in my community nutrition, well, the Farmers Helping Farmers is an NGO that works with mostly farmers, and it has tried to incorporate the nutrition aspect into it. So I came here in mind thinking it's going to be agriculture, and I got to learn that probably it's even more. And learning with, I mean, the integration between classwork and traditional aspect of nutrition, they got into intertwined in the process. So got to learn a lot. yeah, that was my experience so far. Thank you.
Thank you so much, Arnold, for that. So, Millicent, if you're ready, you can just tell us expectation versus reality back then. Did they meet your expectation, or along the way you're like, well, in reality now? So, thank you.
Okay, thank you. So I've been on 3 attachments so far. One in first year, the other one in second year, and the other one in third year. And I was privileged to experience both the private hospitals, a level 5, and a dispensary like a level 4 hospital. So initially, when I was in first year, I expected, as Arnold said, textbook application. And you remember in first year, we were very green. So when I went to my first attachment in first year, it was in a private hospital. I felt that uh, it was more of having the basic knowledge and then tailoring it to your specific client. So when I got into second year, I kind of had the idea of, you know, getting more information, doing more practical, application of the content. So yeah, my initial expectations was our technical application. But in my second and third attachment, I expected, what do I call it? People to come to me, like clients to come to me. I expected, oh, you're overweight. You're coming to the nutrition office. Oh, you realized you're diabetic. Automatically, you come to our office for consultation. And then I realized most clients don't do that. And it was kind of an interesting discovery. Like you have to really explain to the clients and to the patients why they have to see you, why they have to consult you, why it's beneficial for them, and all of that. And then again, the other expectation was probably, and I'm sorry to be saying this in front of all the 6 of us dietitians. I felt like maybe we have more opportunities, we have good pay. I go to the ground, I realize, oh my God, we're being paid. Honestly, allow me to say peanuts. So yeah, I've been thinking of how to maybe, supplement my career and make myself, earn more. I don't know. But so far I love it. I love being a dietitian. So yeah, those are my expectations versus reality. I expected us to be paid. Like when you Google a dietitian salary, it comes around 100 and something. And then you hear people who are employed for like 5 years are getting 60, 70. Anyway, yeah, those are my expectations versus reality.
Yes, so those are some of the challenges. I feel like as the life goes on, you're going to talk more about it. So, Sylvia, when you're ready, you can tell us your expectation versus reality. Sylvia, I don't know if you can hear us.
Yes, I can hear you, Charity. Okay.
Yeah, so it's
So
your
for me,
turn.
what I expected, the fear that they. Okay. Okay, thank you. So what I expected, the fear they sell to us that. Excuse me. Okay, sorry for that. So for me, what I was expecting, that like the fear they sell to us, like you're going to be used, you're going to work so hard, like you're going to work like so like the nutritionist, how the nutritionists use the attaches to do their roles and they don't do their roles. So me, I was going into attachment, I was expecting to do like all their roles. So the first week after orientation, I was expecting like now they have told us what to do, now we know what to do, and we'll be doing it to replace them, to replace their roles, and they won't be doing it. So that is my first expectation. And also, my second expectation is that, you know what they say, like the nutritionists are not being recognized in the are not being recognized. Like, what are the roles of a nutritionist even? So me, I was going there like, hey, like you'll know, like people should know what we stand for with the nutritionist. But at Pumwani Maternity Hospital, that is not the case because nutritionist roles are being recognized and it is actually taken into consideration as an important factor in healthcare system in providing care to the patients. So yeah, those were my expectations going into attachment.
So, what are some of the reality, did the expectation and reality kubaliana, ama at some point your expectations were like, well, I expected too much and the reality is different? Sylvia?
So the reality, as I've said, going into attachment, in that, like I was expecting, like the nutritionist roles are not being recognized in the hospital. So at Fumwani, you're actually, especially at the NBU, you find that a nutritionist is very present there, and the roles are being recognized in them in providing care to those neonatal babies. And also, you need to be there to teach mothers how to breastfeed, how to express their breast milk, to provide their psychosocial support. You need to be with them to ensure that their babies are feeding and gaining weight. Like the very low birth weight babies, they are usually below 1.5 kgs, and those that are a bit well off are 2.5 kgs. So it is very well recognized. In fact, without a nutritionist, you cannot do anything. So yeah, so that is the reality as opposed to what I was expecting. Like like just nutritionists are just there for the sake. Like it's actually their role is actually important in providing care in the healthcare system. Yeah, thank you.
Thank you so much, Sylvia. That's a very positive reality versus expectation. So, Sharon, when you're ready, you can also share your expectation versus reality. Did it match or more? So, you can unmute and share. Thank you.
Yeah, so I've also done 3 attachments. During my first one, it was in my first year. I expected to be very insignificant, actually, because I felt like, I don't know, this is a medical course, and definitely a lot is expected from my position as a nutritionist. And I felt like I was not very well versed with my course. So I was thinking that I would be very insignificant and things like that. But when I got to Nanyuki Teaching and Referral Hospital, I found myself being very useful. Uh, the nutritionists there were quite supportive, actually, contrary to my expectation that I wouldn't have much support, and I will feel, like I'm a little bit lower than the rest. But they were very supportive. They encouraged me, they were showing me around, they taught me close to everything that I didn't know. Like, they taught me everything that I didn't know. So that is something that I really got, and it was yeah, I got support, which I didn't expect. I expected to feel very insignificant and to do, to have nothing to do. But I got a lot to do and I felt very useful in that hospital. Okay, something else I expected during my second internship, okay, attachment, I expected a lot of, even during my first, but it's an observation that I made that we will like have a lot of theory, whatever we have learned in class, sorry, we will be able to like, apply it on the ground. But then I found out that because the community in Laikipia is very, dynamic, so it was more of your experience with these people, your social understanding, your cultural understanding, to be able to even connect with them, speak, have a conversation, understand them, and be able to, just intervene generally. So I found that even yes, bookwork was important, but there was more expected from me than just, being able to diagnose something and intervene. I was expected to communicate. I was expected to, support these people emotionally, understand their social backgrounds and things like that. And I didn't expect such a versatile, a dynamic community actually. During my third attachment, I expected the same. I expected to be able to do a lot at MPSHA. But actually, I think that was, it really didn't happen that way because I did quite less. In that, it's a private hospital. MPSHA is a private hospital and NTRH is a public hospital. So I think that's the difference. But nutritionists like lack the autonomy to, intervene, to work and everything like that. And that is something that really made me feel a little bit, yeah, this is not the position that nutritionists have to hold. Yeah, those are my experiences in my 3 attachments.
Thank you so much Sharon for sharing. So Lillian, si tumekuwa kwa soko sana. I don't know if you can still remember if your realities and expectations were met. Najua si tulikuwa another end.
Okay. I don't know if I am visible enough.
Yes, you are.
I am listening to their positive remarks, and I'm like, yeah, they found it easy, but it is well. That is what growth looks like. So maybe, contrary to what most actually think, by the time I was in second year, I was set on training, getting my degree, exiting the career. So you can imagine when I went to my first attachment, I had very little expectations. So I got there. We thank God we had a very good head of department. She's called 𝐼𝐴𝐵. She's still one of my biggest mentor to date. So she welcomed us. She understood the phase that we were in life because sisi nao tuliwasumbua. Sisi tulisumbua sana. And they responded with kindness, with empathy and all that. So maybe my biggest challenge was, I did not like the idea of working for free. And in our time, we used to work. Ulikuwa unaenda hata mpaka Saturday. Na wewe ni student, you're in second year. Remember tujaanza clinicals, ndo unaenda kujifunzia zingine hapo. So apart from working in the actual hospital, you still have to now ensure that you go back home, unasoma, you're getting up to date with the pediatric protocols, ukienda diabetes, ukienda huku. But that was a challenge. And by the time I was done with my first attachment, I had some really personal interest in clinical nutrition. And I started aligning myself to try and see if I can work in the nutrition space. And then I went for my second practicum. I went to community setup. That is basically in Korogosho in the slums. So my experience was also very different from the clinical one because over here now you're dealing with the community. So the masses were many. You were talking to more people per day than in the clinical setup, but you're also doing less clinical aspect, of course, as expected. And the exposures, the risk was serious. I remember my first accident, tulivutwa na mtu akijaribu kutuibia tukianguka, tukitoka one of those mapping we used to do. We used to go to the community every Wednesday. Of course, it was supervised by the area chiefs na watu wa hiyo area ndio tusinyang'anywe. Basa tukitoka tunatoka na pikipiki. So my friend and I, we were the last people to board the boda. Tulikuwa tunashare back to the facility. So this guy comes in out of nowhere, decided to grab my bag. Tukivutana kidogo because the bike was going, panic here and there, kitambo niachilie bike tulikuwa chini. So I think those are some of the challenges that we faced. But the community was not so bad because I stayed there even like after graduation. I stayed an extra good 1 year before, like after clearing my coursework until graduation, and even like I carried to the following month. But it was also because there was better reception than the clinical setup. I will agree to that. But it doesn't mean that I had hostility in my clinical attachment. No. It was not hostile, it was good. But of course, because I went there without expectation, it was better than I expected. And of course, the clinical cases, they shocked me. They shocked me by the emotional burden that you're not being told in school. The madam who was actually she's now a professor. Let me just accord her the respect. By then she was a doctor. The doctor who was in charge of practicums, she just told us, she gave us a logbook, she gave us hizo documents za kufill in when you're going to attachment, but she did not prepare us of the emotional burden that we were actually expecting. Maybe the proactive students, because me, I was not a proactive student, I will not lie to you, I don't want to lie. Maybe the proactive students who followed her got to understand the emotional burden that they can actually expect. But on my end, it was a shocker. Like, I did not sleep. Like, I remember the first guy who died. I remember his name up to date. He was 17 years and he died when I had gone for lunch. We had just talked, and when I came back, they were packing his body. That thing tormented me for a long time, and I was like, maybe this thing is not meant for me. But here we are. I really do like being a clinical nutritionist. I don't know if I am allowed to talk about internship, but it is well. That's part of my attachment.
Yes, you're allowed. You know, just to be sokoni, Lilian. No, you have a lot of experience because internship days are the problems.
Internship kulikuwa na shida. Internship is unnecessary. Let's get it clear first. It's necessary for us officers to get interned, to go get that exposure. Now, the 2 years between, or the 3 years, let's just, because the last I left Provide in 2015 when I was joining I was now setting up for masters. So between 2015 and 2017, I developed some emotional resilience. I developed some emotional intelligence. So I knew how to respond better. Of course, I did not have kifo tunaongea nao tukiwa comrades, unaona? When you're in school, kuna kifo unaongea nao unajibu watu na comradeship. I had it. So I had to develop that. I had to develop how to talk to people. Of course, there are things that I was doing that actually forced me to learn how to make sure that I am communicating and making sure that I am being heard. So I think that was one of the things that helped me during internship, because I was able to separate the issues that I was facing with internship and my personal issues. Of course, there were those who are overlapping. I was listening to your video the other day, Charity, and I was like, this nurse, and it reminded me of my experience, almost similar. And I'm telling you, we almost fought. We thank God for other people who were in that room, because me, I was ready to fight. I was like, no, you cannot undermine my efforts. I have justified for you. It's not my fault that you don't understand why I'm telling you that you cannot feed my diabetic patient yogurt. I am not going to allow you to do that. And it was in the ICU. But we thank God, I had a very good mentor in clinical nutrition in that facility. But the reception that I got there was very hostile, because they were like, umekuja unajifanya. You know, my mentor told me, when you're doing your plans, be very firm and tell them that they have to do it. Because if you don't tell them they have to do it, they won't do it. So me, I was telling them, I was waiting for them. And then when I was coming up in the morning, I was asking if they did it. So if they did not, I would ask why. And then someone will come and tell me, basically the nurse, that they found it so hard to just like ensure there's maybe the bag that was being dispensed overnight, that it was dispensed. So they just thought they gave the patient yogurt with a syringe. And that was my bone of contention. And we really almost fought. So she called the supervisor for that department, and we also not seen eye to eye. Tulikuwa hapa pia, kulikuwa na shida, kulikuwa na sparks. So when she came, she was like, I'm going to call Candy. I'm going to dismiss you from the internship. I was like, I am working for free and you are threatening me. Are you even serious? And the worst thing, like being an intern, like you are working and other cadres that you are working with were being paid. So end month, watu wengine walikuwa wakiserereka, wakicelebrate, wakilive their best lives. You're there as a nutritionist, you really struggle. See, it was emotionally draining. And I thank God for that experience, because we consolidated our experiences globally, not globally, countrywide. We formed the WhatsApp groups and started a movement, and you all have seen it. So that experience actually triggered that, because we understood that matters za labor, hata tukitetesha KNDI, there's very little they could have done. We even went to try and I remember he's a good friend of mine, so I'll not mention his post, but one of the NAC officials came to the facility to threaten me and my other few friends, because we had really now steered the movement. They were like, you're going to make sure that you will never practice in Kenya. I was like, yo. By then I was almost sure I want to leave the country. I was like, who needs it? Kiburi ilikuwa inanifika huku juu, but that is not a good thing. So if you're an intern or if you're a student currently, kiburi ipungue. But sometimes it's good to stand on your grounds, especially kama you know what you're saying is right. It's very important. You cannot be ati mtu anakuja anakuambia your plan will not work, we do this. If you have justification, if you have the guidelines, if you have backup, stand on firm. Me, I used to do that. And I remember another one in internship. I'm telling you, I had issues. Another one in internship, she was like, najiona kierere, najiona mjuaji, I should know that. I'm not saying degrees are better, but I qualified for it, hiyo ni kiburi yenye hatufai kukuwa nayo. I qualified for it, and this person is trying to make me feel like it was a wrong thing for me to do a degree because she has a diploma or a certificate or whatever she had. So me, I told her, mimi sikukuambia akili sifanye. I told her exactly the exact one. I really told her off, and unfortunately that was not very mature of me, but I am glad I did, because vitu zingine, you cannot come and start telling me ati watu wa degree mnajionanga mnajua, hamjui, the diploma course, blah 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 blah. Let's be realistic. If it was that effective, we'll not be having a lot of malnutrition cases in Kenya. That is a reality. If nutrition, if the degrees was useless as they actually claim, or they say that they are irrelevant, would we be having issues? No. If we had actually capitalized and utilized the degrees training that we have in Kenya, I'm sure we'll not have a lot of unnecessary issues that we have. I know I'm going to get a lot of hate on this, but in life, sometimes you just have to say the truth, and life moves on. So I am hoping that what my internship taught me is sometimes it's okay to even be as loud as you can be when you're feeling oppressed. It's okay, by the way. And mtu asikuintimidate, by the way, ati because ati people want to project their insecurities, people want to project their inefficiencies on you. You've come there to train, and they're supposed to train under you. You're supposed to train under them. They're supposed to lead the way. But of course, some of the questions that someone I really relate with closely usually asked: how does a diploma holder actually supervise a degree? holder. These are some of the things, the mismatch that we have in the nutrition profession that we are hoping that soon they're going to be solved. We have to be realistic about it. Hii kusugarcoat imetuweka pali tuko hadi saa hii. So we cannot be having this. That is why we are even not taken seriously, because unapata mtu hata ako na certificate, they are a whole supervisor because of a shady career thing, or because they're supposed to set some standards so that if we are to be taken serious. The other day, actually this week, I was with one of the senior ministry leaders. I will not mention the name. And he was like, if you allow to be mediocre, if you allow to, he didn't use the exact words, but this is exactly what he said. I was with the SG because we had some consultations. It was like, if you allow your cadre to be mediocre, if you allow yourselves to be taken like cadres who are not relevant, no one will take you serious. And he gave me an example. He was like, look at our nurses, look at our clinical officers, and even look at our farm techs. We take them serious because we know what they deliver and how their impact actually has on our health system. But now when it comes to nutrition, we are taking things lightly in every aspect. We are taking training lightly. We are taking regulations lightly. But we thank God that we are not having some issues that we had back then. So I think things are going to be okay. And staki kuchoma sana, because I still love our diploma holders, because let's be realistic, kitambo hakukuwa na degree in nutrition, so KMTC had to come up with training, and I thank God for that, for them, because their training is thorough, and vitu zingine kama kulower grade, so unashanga if with their thorough curriculum, how are they going to actually help the country? So I think moving forward, you're going to make sure that we strengthen our diploma and make sure that we are also utilizing our degrees, and vitu zingine kama certificate, we should start a movement to do away with them, so that we don't have those inferiority complexes. If someone is feeling like ukikuja hapo na degree, unataka kuchukua kazi yake na we ni intern, ama unataka kumuonyesha venye atafanya kazi yake, you're there, you've shown goodwill, you want to learn, but someone, also a good friend of mine, I wish she can come here, but I know she will not actually talk about it because she's not comfortable talking about it. We were with her in Thika and she really suffered. She was being told when Kierere, like, and how she's diabetic, so she was not willing to fight back. She will just go and start complaining about it. And it can demoralize someone. Then if now they find out that you're doing masters, you're an intern and you're hiding from your fellow professionals that you're doing masters. I am sure there are people who never knew tulimaliza internship kama wajui mimi nilikuwa nafanya masters, because how they felt threatened by just the thought of us having a degree. We were like the third cohort. Sindio Charity, the third cohort after the internship was introduced officially, because watu wenye tulimaliza now, wenye tuligraduate now, they went, and then me, I went the next year. So I was actually the one among the second cohort. Yeah, the second. No, I still resisted the second. I was not willing to go, so I was the third cohort. Yeah, so we were the third cohort. No, it's the second. I was the third cohort to go for internship, and it was very sad. So people were feeling like mnakuja mnataka, and then mnaanza kuambiwa hata kazi zikikuja, as someone has said, hata mkiapply mtalipwa kama sisi. Ati the counties do not take up degree, the counties do not recognize degree. We need to keep fighting so that we change that narrative, because it's very bad. Let me stop there, because you're
Yes,
badly.
She's an advocate, so if she starts to talk, she will talk and talk. But what she says, I 100% agree. We were the third cohort to be sent by KNDI, and we never had it easy. That's why in the chat, my friend is saying she's surprised to hear positive feedback from you guys. So I'm like, that's why I wanted a generation of us when it will be the first cohort, and then as time is changing, you can see at least people are starting to embrace nutrition. So Lillian has mentioned something that we were to talk about this, and that is learning and support system. So I think I will start with Sylvia and Sharon, either of you, because you're currently during doing your attachment, how is the guidance when it comes to those people who, how are they, perceptors or whatever, I don't know what they're called, the nutrition department in your area of attachment? How is the guidance, the mentorship, the healthcare team? How are they treating you guys? I don't know if Sylvia can start, or Sharon, whoever is comfortable, and then I will go to Arnold and Millicent and finish with Lillian. So I don't know, between
Okay.
Sylvia and Sharon, who is comfortable to start.
I'll go first. Yeah, although I'm not doing my attachments right now, but in NTRH, the mentorship it's quite proper because they currently have constant, is it like some class sort of classes every Tuesday and Friday weekly. They tackle some challenges that they have come across, and also they venture into some other, like they take up an issue and run with it. So, and then as I said, in at NTRH, some nutritionists are very supportive, 100%. Well, while that is the case, others are quite difficult to deal with. I personally had a had a situation whereby I had trouble doing something, and then I approached one of the nutritionists, and I was requesting for her to show me how to go about it, and she kept telling me, okay, she first of all lectured me around around how that was quite unprofessional. Um, that this is not how I've been taught to do it. I can see that because I was rotating in her ward. I was like, can you show me? Because I've seen you doing it differently. I want to learn how you do it. Then she's like, how come that this is not something that you've learned? How is it that you're asking me this question? So she made it seem like that was a very stupid question, actually. And it was one of the moments that when Lilian amesema, they were an off for me because I literally left that word and, rotated myself to the next one because it was quite a big issue and it was me asking a question and I didn't like how, that was, returned. The other cadres, some are also very supportive. The doctors are they're very, they're impressive in how they interact with nutritionists. Um, the nurses, I think they are yet to come into terms with, especially the older generation, the senior citizens, kinda ish, because I feel like they think they know how to deal with situations that nutritionists deal with. But okay, experience has proven that they actually don't. Most times they have no idea, but they will still insist that they can do it. So they are yet to, be on the same page with us. In the private hospitals, I think there is a lot of work to be done there because private, it's like nutritionists, a big chunk are, somehow insignificant. You have to be A patient has to be sent to you for you to see the patient instead of every patient, or maybe a patient who needs a nutritionist seeing a nutritionist. So like the doctor has to decide whether a particular patient needs or requires a nutritionist, which is something that I find quite, what does that mean? Lilian has just said that how our career is taken, not seriously, while other careers are quite, they are popular, everyone respects them and everything like that. I think one of the places that we should start from is right here. Some hospitals, the public hospitals, public institutions, I think they are running along with it. They are catching up. But the private hospitals, something needs to be done there. Yeah.
Thank you so much, Sharon. Sylvia, when you're ready, you can tell us how the general reception was, the mentors, the other healthcare teams.
So for me, the reception is very well. In fact, the nutritionists there are not, okay, they are millennials, but they're sort of Gen Z. But specifically, that one for NBU, the station where I was rotating for the first 2 weeks. Normally at Pumwani, we rotate in a place for 2 weeks, is Gen Z, and we relate so much. And she has passion when you see her working in the MBU. And she even taught me how to insert the NGT for those neonatal babies. And I was even surprised. I was terrified. She was telling me, like, nutritionists can even do this. I thought personally, I thought like that's the work for nurses and the CEOs and the MOs. So now I'm happy to share that I can actually insert an NG tube. So she shared me very well, and we even learned so much in that station in the NBU. At CWC, the same. At postnatal wards, the same. So my experience is very good. The officers, the nutrition and dietetics officers, including the in charge, they are very receptive and they teach you very well. So that's what my experience at Pumwani is with the nutrition and dietetics officers. Thank you.
Thank you so much, Sylvia. I guess you're having a very fun time. You're giving us very positive feedback, which I'm actually happy because it's a long time coming. And if nutrition is being embraced, I feel like we should really clap for the union. They're doing a good job. So kudos to Lilian and the team. So Millicent, you can take the stage and share the mentorship, the healthcare team. How were they? How was your experience?
Yes. My experience in the three attachments, honestly, in terms of mentorship, has been amazing. Like, I've had amazing mentors. Like, since the very first attachment when I was very, very green, the only thing I knew in relation to dietetics was probably physiology and anatomy. Like, there was nothing I knew back. I didn't even know what diabetes was. Sorry to say. Like, but she was so good. She was amazing because she used to take me to every patient she used to see. So, yeah, it was amazing and beautiful. The second one also, it had over 7 dietitians, each for every department. Like if it's maternity, there was a nutritionist there. And all 7 of them were also amazing. In all my rotations, they all mentored me well, taught me well. And also the previous one, Kennedy, at Ongike Level 4 Hospital, he was also amazing. Used to give us lessons in the morning, assign us duties. He used to call us graduates, although we were in third year. So he used to let us take the lead sometimes. So yeah, I'd say the mentorship has been amazing. All 3 years, all 3 attachments. And yeah, honestly, I learned more from them than I did from class. So yeah, I have only good things to say about that. So yeah.
Hi, to be you guys, to be you guys. Sisi, Lydia, Sisi tulipata Matthias. So Arnold, you can share your experience with mentorship and other healthcare during your clinical and also your community setup.
Yeah, thank you, Sharon. So, thank you, Charity. So, I think for the clinical, I'll have to say, let me cross over to Charity and Lillian. I'm part of you guys. I don't think I had the best. Yeah, I'm surprised by Sharon, Sylvia, and Millicent. Yeah, to be honest, I think I learned a lot from the only advantage that I had was at 𝐸𝐴MBO Hospital, students who are doing MBCHB, nursing, and pharmacy from Kenyatta University were taken for clinical rounds at 𝐸𝐴MBO Hospital. So I used to I snuck in to learn from them. Yeah, but apart from that, I think I'm with you guys on the other side. Yeah, there wasn't so much to learn and more and motivation from my uh, supervisors. So to say, have to couple. I think there was a gray area between supervisors and attaches empowerment. So yeah, so we didn't get so much empowerment from the supervisors compared to like the rest of my friends here. So instead, we had to dig in. Actually, probably if I'd look for my notebook, you'd see how much notes I had written because I was so scared on the first day when I joined the clinical rounds with the medicine students, and I knew how point blank how green I was, probably more green than Millicent. Yeah. So, but from my clinical attachment, it's different because um, it is more of clinic nutrition education and nutrition counseling and advocacy. First of all, speaking of advocacy, thank you so much, Lillian, for being here because she's one of my mentors when it comes to advocacy. I don't know, when I see her nafikiria tu tunazaenda maandamano or something. Yeah, but yeah, advocacy. There's one thing about clinical attachment, the advocacy and the nutrition education and counseling part is the major thing in here. So compared to my clinical attachment, it was very different. But for my community, yeah, I think it's much better because I get motivation since we're having a one-on-one. I only have one supervisor, thank God, apart from my clinical attachment. So during my clinical attachment, I was having someone from diabetes, someone from, I don't know, medical, pediatrics, and all of them had mixed reaction, mixed emotions, and how to deal with people. So yeah, that was different. But here I'm dealing with one. So for my communities working very well compared to my clinical. Yeah, so the motivation is, I think I'll bend much more on the community. But if you're talking of clinical, yeah, I'd like to think I'm on the same page with Charity and Lillian. Yeah, thank you.
Yo, nataka kuliwa na kicheko. Because I do understand being or working with someone who is not giving you any guidance. They just leave you green. You're just there with your oversized lab coat. You don't know what to do, and someone is not helping you. They're not holding your hand. That's why I feel like I'm very happy with the Student Association and their mentorship programs where they bring in real life working class to talk to you students so that you can be able to now bridge that gap. Because hey, see, Lillian, you can just Lillian, I think for you, you have mentioned some of your experiences when it comes to the mentorship and some of the challenges you face. So I feel like we'll go to the next segment, which is a moment that changed you. So Arnold, you're going to start with you. Tell us about a moment in both your experience that really made you like have that moment of realization. You're like, what? Maybe I love being a nutritionist, or maybe I'll want to pursue advocacy, like you said. So you can just start off this segment and tell us more.
Well, my first moment of that I know was when I joined the clinical rotations. So we had guys from pharmacy, from medicine, and then I was there. And I'm right there with my big badge written Stephen Arnold, nutritionist student, Kenyatta University. And so yeah, there's this doctor called, I can't remember the name well enough, something like Turanera or something. And she's like, you're a nutritionist. Tell us they were doing like clinical rotations on a certain patient. Yeah, and yeah, I think that is when I knew. I think I've been sleeping in class or something. Yeah, so she pointed out on like 3 questions as Kifotana, and I was really out. And I kid you not, Charity, that night I didn't sleep. I was studying. Yeah, I was really reading the whole night because I wouldn't imagine how point blank this can be. I can get. I was like the following week when I went for the attachment for the rotations, she didn't ask me a question, and I was really ready for it. But yeah, something that changed my uh, more like my perspective on the whole thing was the clinical rotations, because at Kiambu Hospital we had clinical rotations on Monday and Thursdays every week. So we did more like a holistic approach, which encompasses MBCHB, pharmacy, nurses, and nutritionists. So we'd go to a patient and discuss, probably depending on the 4 dockets, how many we are. We talk about maybe a patient who has a certain disease. So, and the MBCHB guy will talk, the pharmacist will prescribe a drug or something, the nurse will talk on how, the nurse care, and then the nutritionist part had come up with the diet and how we're going to manage this patient. So, yeah, these clinical rotations made me change my perspective on how things run in the hospital. And if you guys can remember, when I was with Jojo Molo at KBC back in, was it April or March? Yeah, we were at KBC and I was talking about the Health Act of 2017, on how it talks about holistic approach on how doctors, nurses, pharmacists, and nutritionists will work. However, it's not implemented, but with this small aspect of the clinical practice, I got to see how this thing can be translated into the practical aspect of handling a patient. So I think with the clinical rotations, it really helped me with gaining more knowledge. Yeah. So I'd probably say that. Yeah. Thank you.
Thank you so much. And I am laughing because if you wear that badge, I feel like most of the time, I don't know if it's still the case because it's been a while since I've practiced. You have your name tag, but you've tagged it in your lab coat because of the fear of being called out, because you're in a ward round with it was a huge crowd, especially in KNH. It's a huge, like, I think the whole ward is filled with, and then your badge, and then the consultant calls you nutrition, and you don't know, and then you freeze, and everyone is looking at you, and then you start to have that imposter voice. So I 100% agree with Enold. So Millicent, you can take us through that moment that made you love. You said you love being a dietitian. So what changed in the 3 attachments you did?
I think my change didn't really come from the attachments, but okay, the attachments are mostly curative and managing conditions. I don't like that part about being a nutritionist. I don't like feeling like I'm not doing much sometimes, especially I don't like working in an hospital setting. Like in my 3 attachments, many patients have died that somehow our team was managing, and somehow it's traumatized me for some time. I remember going home and telling my mom the first time someone died and I knew the person and I was managing the person. I told my mom and she was like, "Utaweza kulala leo usiku?" Like, because I was actually crying when I was explaining. Now I can't deal with that forever. Seeing people die, people who are managing. So my aha moment has been a culmination of things from the 3 attachments, schoolwork, people's experiences. I actually prefer preventative, the preventative part of nutrition, like the holistic. part of nutrition, having to not take medicine. I don't know, maybe sometime in the next 5 to 10 years, I might be the next Dr. Sabi in Kenya, you guys, teaching you how to use herbs. So yeah, my haha moment came as a culmination of all three. The very first one was in the very first attachment when the very first person I was managing died. I knew I wouldn't do clinical practice, clinical nutrition. So yeah, right now I'm still trying to find what I want to do in the nutrition space. But yeah, I might be the next Dr. Sabi. Yeah.
Which is also okay, because for me, also, my aha moment came when you're managing stubborn patients. You see them deteriorating, but they don't want to listen to you. And you're like,
Mm,
"What? This is not for me." And it's okay. It's okay. That's why you
yeah,
go for
that's true.
attachment and internship for you to know what best
Mm,
suits you. So for me, I usually tell people who come to me and ask, I'm like, you do what your heart wants. If you don't want to be in the clinical practice and you practice, because I did clinical both. I went to 𝐴𝐻, I went to Gertrude, and then my internship, I went to Machakos. So all of them were in the hospital. But right now, I don't want to go anywhere near the hospital. So it is okay, Millicent. Yeah. So I think we'll go to you, Sylvia. I know you're having a very positive and happy time. So I would love to hear, like, is it steering you towards maternal and child nutrition? Because I know Pomani, that is mostly what they do.
Yes, I can say that is steering me towards loving this course more. So, what made me realize that I love being a nutritionist? In fact, me, when I was in class, we are learning theory. Me, I wanted to be a renal dietitian, just prescribing diet for patients. But here in Pumwani, working with mothers, seeing the challenges that they are facing, low milk letdown, breast engorgement, seeing the struggles from the mothers of the NBU, the mothers with babies with infections. Like you see, a baby has improved the nutritional status, and once again is going back to room 6. So at Pumwani, when you hear like a baby is going back to room 6, that is things are boiling now. So that is the room that babies with infections like the intestinal infections are kept there. So, and also the interval of weight gain. You see, like a mother is really struggling to make sure that the baby is gaining weight, expressing the breast milk, breastfeeding at the same time, and topping up with the express breast milk. And then the baby is not gaining weight. Just seeing the struggles, I realized that maternal and childcare is really close to my heart and is steering me more towards becoming a nutritionist. So I love this course more and I love clinical nutrition. Yes.
Thank you so much, Sylvia. We'll be watching that space. I usually take keen interest and I follow you guys. So to see like the upcoming generation, I feel like this is generation yet we really had a hard time. So Sharon, you can tell us during all your attachments, what was that moment that steered you towards wanting to be a nutritionist or loving what you're doing right now?
Okay, I hope you guys can see me for the first time in the night. Yeah, so this one day, I rotated in the surgical ward, and then the surgical ward had, all types of cases. Then I met this one lady. It was a particular cube. I think it was cube 4, and then they were one patient had a diabetic foot. Uh, she had one of her nini. I think it was her left foot. It was amputated, and the other foot it also had a diabetic foot. And then there was a girl. She was a teenager at the corner. She had just broken her leg. And then at this other corner there was a lady. She was a CA patient. and I found her, and so I just said hi to her, said hi to everyone in the cube, greeted them, happily, asked how they were, asked how they were doing. The nutritionist in charge introduced me as a nutritionist intern. Oh my god, nutritionist, yeah, intern. So when I started talking to these patients, I learned that the CA patient has not been feeding, and she has not even tried to sit up on her bed, even for the longest time possible. Now, what I did, I started encouraging her to try and sit up every single day. I just walk in and ask the others, you guys, you need to encourage her. You need to tell her every day. When the food is brought, make sure, if I'm not here, make sure she has eaten. Make sure she has tried to feed. And, it was metastatic and it was stage 4, but at the same time, we can still do something. So, my patient at last ended up sitting up one fine day. I helped her up. She held onto the bed, and she just you know, sat up. And then I really was very proud of everything that had happened in that cube. The patients being like, I'm telling them to encourage her, and then every single time I walk in, they tell me, it's like a report. She has not eaten. She ate sijui half of the food. She has not drunk her porridge. She has not done this. Yeah, we asked her to sit up. They all have their issues, but they are really encouraging the other patient. And then I just come in, and then it's like everyone is just telling me, Sharon, this and this is what is going on with me. And then this patient improved to the point that she started walking. So she could walk out, and then go and sit outside, come back. And then I rotated out of that ward and went to the medical ward. And then this a fine day, I just decide, let me go and say hi to them, only to find her bed empty. And then I asked the others, where did she go? And then they just told me she left. I'm like, where did she go? She went home, or what? Because I could not expect that she had died or something like that. So they just told me that she packed and things like that. I was so heartbroken to the core. And I tried to imagine the entire, the how much effort I was trying to put in to make sure that she, like she tries to live up her life. With my other patients, the one who had diabetic foot, they was like the patients in that cube were like very diverse, and how much effort they were all putting in each other's recovery. And then I just thought to myself that maybe this should not be happening here. Maybe this patient should not be here, the diabetic one should not be here, the CA one, maybe something could have been done. And that's like I got this of the feeling of it could have been better if they knew about it before they got here. You understand? And that's why I lean on to where Arnold is the community. Like the community needs to learn. The community needs to know. It shouldn't get to this point. Yeah. So in that process, that entire period, I felt my heart really. I leaned onto NCDs. I leaned onto the community engagement, education. Well, it's a lot, but that is one of those points. Yeah.
Thank you so much, Sharon. Clinical for me, I don't know. Lillian, you're into advocacy. You can tell us from what you talked, you could see where the advocacy came from, but you can just share briefly where that moment that from the attachment to the internship and our experience shaped how you're practicing right now.
Thank you, Charity. And maybe just to clarify, just because I had small sparks here and there with my mentors, does not mean I did not have great mentors. By the way, some of these people that I have actually even told you their experiences, we are really good friends currently. Yeah. So sometimes you learn, you fight, and then you grow. So do not be scared. Alafu saa zingine let's avoid holding grudges, because people owe you nothing. That is the sad reality of life. People owe you nothing, so small disagreement here and there is kufanya ushikilia watu grudges, because you will meet those nurses in those training that you'll be going. Once you're a professional, you'll meet those professionals as well in summits and discussion conferences and such. And of course, some people like us might hold grudges, but kidogo kidogo inabidi tukue liberal. So me, I knew I wanted to be a clinical nutritionist when I was in second year. Let me tell you why I wanted to exit the career, but I still knew I wanted to be a nutritionist. So when I went to PEDS, I got a very good pediatrician. She was hands-on. Unaona ule mtu mwenye ni mkali, ukichelewa 5 minutes, you're not attending her ward round. If you stammer, akikuuliza kitu mbili anakuweka kando, she gives you like 5 hours. She was expecting you to be perfect. So I remember, and if I checked her age, she was not even like maybe 40s. No, she was a bit young. So I was like, I want to be able to manage, because she used to emphasize on the importance of nutrition in pediatric. And when I went back to school, even my project, I did it on babies, and it was basically rickets and malnutrition. So I did that as well. And when I cleared campus, when I was applying for internship, I had the option of going to public health, because and also community, or even other aspects of care. But I did not. I specifically chose clinical because, one, it was convenient for me by then, because I did not want to leave Nairobi or its environs. So me going to Thika was convenient for where I was. But at the bottom of my heart, why we were fighting with so many nurses is because I could not stand to watch them mismanage my patients. That was our biggest bone of contention, by the way. And anytime I will tell you, or I will write for or communicate about a certain intervention that I wanted to be implemented for the patient, I will go the extra mile of even trying to explain to you outside the files why I've done that. So anytime I will come in and I will find my patients, maybe their blood sugars have spiked, I would really get annoyed, because sometimes when you're in a clinical setting, it does not mean that all your patients are critical. Some are still talking. So you would ask them, they will tell you, niliambiwa nikule usiku, nikaambiwa hizo stories zako za kufanya hivi nisifuatilie, lakini pole sitafanya hivyo tena. So I got to meet a lot of people, and that joy of someone getting out of the hospital, then they come back to the facility to thank you, or even their relative to come back to thank you for what you did for them, actually made me now decide I need to practice nutrition and I need to make it work. So unfortunately, because of the rates of unemployment and issues here and there, I did not manage to get into the counties. So I decided, okay, fine. Do I do the career? Do I do a career change? But you see, by the time I was done with the internship, I was already involved with advocacy, because of when we formed the groups for internship, because we formed it when we started the internship. That was basically in February. It was in January. We formed the group, and then we were adding people. So we were like more than 500. That's why KUNAD has some other groups that are so many, and others we are not actively communicating there, but we are still doing the communicates there, because by then I think there was a limit for 257 on WhatsApp, so we had to open like many other groups. And I remember my SG telling me, because I wanted to leave the country. And he was like, tukiachia hii kitu hapa itazama. So I decided to stay in 2019. Then he wanted to leave. Now he wanted to like do away with nutrition, because unajua pia ni stress, trying to come up with ways to talk. And like, we thank God, sometimes mtu anatesekanga ndio kizazi isiteseke. And I usually encourage the ones that are actually struggling, because I attended one of the webinars, and watu walikuwa wanasema ati nutritionists are not recognized. Yeah, we've come a long way. Charity can confirm that we have come a long way, that to even see that counties are employing annually, but the numbers are a bit slow. But we are going to try and make sure that they are better, and to try and make sure that people who go and study nutrition for 4 or 5 years are not suffering. because you're also going to push for the internship to come back. And I need to clarify one thing, that if I was to go back to 2017 today, I will still go for internship, because that made me a clinical nutritionist. It made me understand why I'm a nutritionist and the role of nutrition in disease prevention, management, and actually the patient being cured or treated. Someone was giving a history of a cancer patient, others diabetes. When nutrition intervention is properly implemented during the care plan or the medical care team for the patient, research has shown that people recover fast, and we have seen it. Like, I saw it. I was practicing, and I was like amazed at the same time, because I was like, yo, yeah, it happens. Because you remember, in your attachments, if you can confirm, sio kila mtu anaendanga ICU ama the HDUs ama the specialized clinics. So when I was doing my attachment, I did not go to all those clinics. I just did the common ones. I did the MCH, I did pediatrics, male and female surgicals, and then I did CCC. But you see, now when I was in internship again, kulikuwa na strike. So, and then nutritionists had no union, so they were the only cadres and records who were working. Daktari, CEOs walikuwa wanakuja tu kuinterchange. They come in, they give you one thing, and then they disappear. Now you had to make sure that at hapo hata like wakitisha saa zingine uko hapo unasaidia na kufanya CPR. So we got to learn a lot. I got to learn a lot during my internship, and yeah, I think that is the moment that defined or made me actually want to be a nutritionist. And advocacy, tuseme tu ilinipata by mistake. Arnold, mi sipendi maandamano, mimi ni baby girl. It's just that sometimes I am forced to attend them. And sometimes unajua, when you understand the course, kitambo mimi sikuwa na understand, because I remember ya comrades ya KU when I was in first year, nimeingia tu campus na sijamaliza miezi 2, watu wanaambiwa kijana ameuliwa, tunaenda kuchoma Thika Road. You're thinking, oh my God, what is wrong with people? So I remember calling my mom and telling her I need to go home. So I went home immediately, because sikuwa naelewa kwa nini watu wanaenda kwa barabara kuchoma Thika Road, because someone was mistakenly killed hapo KM. So advocacy, yes, I have always wanted to talk. That I will not lie. I've always wanted to talk. I have been a very outspoken person, even when I was in campus, when I was in high school. People can confirm, people I went to school with, even primary school, I used to be able to communicate. I can communicate. I can tell you what I want you to do. And in high school, people used to tell me that I talk without fillers, because I will not sugarcoat things. I will tell you as it is. So I think advocacy came, I will not say naturally, because I'm telling you, I never imagined even at any point that I will be doing maandamanos. I knew maybe I was going to do journalism. After clearing my internship, I knew that I wanted to do health advocacy, but not like the unionism. Like, I wanted to be an health advocate. I remember thinking that when I just finished my coursework kwa masters, nikifikiria I should have done health policy instead of masters, because I was like, I want to talk about advocacy. But again, I thank God that everything happens for a reason. So I thank God for what happened, and I don't regret. Honestly, I don't regret. Sometimes someone will tell you, being a unionist, being an advocate, when you're talking so loud about things, no one will want to work with you. People will hate you when you tell them the truth, but at some point they'll have to accept that the truth is the truth. So me, I came to agree to the fact that nilishaanza, sota nikiacha itanisaidia, and if I leave, I will leave the profession not changed. So there are things that I personally nilisema ni goals, and then once they are achieved, then I'll be able to exit comfortably, and I'm hoping that they'll be achieved soon. And I have seen progress. I have honestly seen progress, and I'm hearing progress from these people who are currently sharing their experiences, because I can tell you, for us, it was not easy. It was not interesting. People did not even like it. Some people walikuwa wanakuja, wanaenda wanakaa kwa tea room, wana complain for 2 hours, then you go back to the wards. We used to do that a lot. Like, Thika tulikuwa na place tunaenda kukaa kama nutritionist peke yetu, tunakaa watu wana hate alafu wanarudi tena kwenda now serving patients when you're that frustrated. So I think a lot has changed, and just for clarity again, I said I'm still going to stand with the fact that maybe we need to do away, of course not maybe, we need to do away with training vitu kama certificate in nutrition, because currently the diseases that we have, expertise hiyo capacity ezisaidia sana, and as we have seen, we are having even CHPs. So mtu atrainiwe kwa nini aende shule ku waste na anaweza kuwa CHP bila hata kusoma hiyo shule, So I think we need to be realistic about it, and advocacy is not easy. Let me tell you for a fact. Clinical practice is easy. Of course, it's mentally draining. Watu kukufa. I am still practicing, by the way. If you check me, I am very much licensed, and my license is up to date. And even if now I work, because I have patients, I consult patients that I go to see in the wards. Even if I go to there, I am able to effectively manage my patients. So I stay up to date. So mtu asikudanganye ati utakaa tu na umekaa tu na unajita clinical nutritionist and you cannot deliver. No, we need to stop embarrassing the name. So yeah, I think I'm na deviate. Sitaki kudeviate sana. Charity.
Lilian, when I went to Kikoga, I went to ongea for 2 hours, but ni sawa tu. Yeah, I agree with you that I wanted this question to really be talked about in detail, because someone might be out there in the attachment or in the I didn't even know I'm a scrape of internship. So how are you guys getting the training you need? Mna volunteer anyways, ni sawa. So I feel like time is really not on our side. So I feel like I will combine the two questions so that we can finish on time. So we're supposed to look at the emotional aspect. Lilian mentioned also, and some of you also mentioned, when you face death, you're like, what, this is not for me. So, and sometimes you have to balance that and still deliver. So the aspect of sympathy and empathy and making sure they don't intertwine in your practice. So I'll want each one of you just briefly to talk about the emotional impact, and also talk about what gaps have you noticed. If you're done with the attachment and you're doing, what gaps have you noticed, and some of the growth areas you would want, like sort of your recommendation, because I know July, most of you are almost done with your attachment if you're in, so at least you've come up with something, because you're going to write a report at the end of it all. So I'm going to start with Millicent. You can tell us the emotional burden, how you navigated, and also what gaps you noticed, and some of the growth you want to see, like sort of a recommendation, and then we'll go around as we wind up. Millicent?
Yes, I have a question. Is the emotional gap specific to my experience, or?
No, because you're already done with your attachment. You can just say like that feeling, that emotional, because I know some of you, if you're not used to the clinical aspects, the emotional trauma can be very real. 4 months down the line,
Yeah.
you're still feeling from that patient who didn't listen to you, that patient who died, and you were just reviewed. So generally, because you're done with all your attachments.
Yes, my emotional burden, I stated part of it when I said every time somebody I manage dies, whether I kind of feel like I'm to blame somehow. Like I feel like maybe I should have studied better. I should have looked into drug nutrient interactions more seriously, maybe whatever they were taking. I should have, I just feel sort of responsible. So yeah, one particular case I remember that I'm very sure it was somehow the fault of us as a nutrition department, was still in first year. I remember there was a patient in ICU that I can't really remember the exact condition he had, but I remember tukiwa ward round, sorry for ward round. I remember the dietitian whispering to my ear, dawa zenye huyo patient anapewa zita interact na supplements zenye sisi tunamwekea. And then she never spoke out. And then I remember us coming the next day and the patient was gone and the cause of death was drug nutrient interactions. And I also never spoke out. So somehow I usually feel like I am very heavily responsible for that because I was a coward. So yeah, the emotional burden for me, I just deal with things differently somehow. Like, I don't know, but death is really, it's something that I don't know how to deal with yet. So yeah. And then the other thing, the other emotional burden is sometimes when I was at Wangige Level 4 hospital, it's mostly caters for the low income earners. So a patient comes to you, they are maybe extremely malnourished. This is an adult client. They have kids who are also malnourished. You give supplements, but when you listen to them, they themselves are not even capable of affording the basic meals. So you're telling them, you're giving them nutrition counseling, but actualizing it for them to maybe follow it up, they'll need some sort of resources. So you kind of feel very sorry for them. But all you can do is just give RTFs. Like, you can't do anything else more. You can't support them financially. There's no relief food at the hospital. Like, it's just a lot. And also seeing parents come consistently with malnourished kids. Maybe they're not improving again because the parents are not able to afford to feed them. So the whole situation just makes you feel helpless. Like you can't do anything for them. Yeah. Yeah. And then the gaps that I've seen, I think what Maore said, there's a really, I don't know if there's some sort of enmity between us dietitians and maybe the nurses or some medical practitioners. I don't know what sort of enmity exists between these two cadres, but sometimes you may write a meal plan, but the nurses intentionally fail to follow it, and then your patient suffers the consequence. Or sometimes during ward rounds, sometimes we're really sidelined. Like everyone is giving their opinions and umesimama hapo mbele kwanza na unaskipiwa. No one is asking for your opinion. The consultant doesn't care about the nutrition department. Yeah, kwanza hizo hosi mbili, the very first one, hiyo ya Chogoria and Chuka. We were never consulted. We just had, ni wewe uone shida useme ona, I suggest like you have to be really vocal about the whole approach and care for the patients. So yeah, that is has to be addressed. There has to be some sort of, and yes, as Lillian said, find our foot in the clinical space. We really need to have because again, it's a new course, it's a new career path that we need to prove our relevance. So yeah, those are the two gaps I'm mostly saying.
Thank you, Millicent. I don't know if you're still talking about the network in Asumbua. Arnold?
I'm done.
Okay. Arnold, you can just do the same briefly because we're almost out of time. your emotional burden, the gaps you noticed, and the growth area.
Okay. Um, I think the emotional burden was finding the thin line between patient empathy and professionalism, because I see from the panelists here, most of us are from KU. We all know Dr. Mbide, who taught us counseling and education. She was teaching us about how to be professional. So when I go to my clinical attachment, yeah, I think that is where I found the humane and the emotional empathy part and the professionalism part being almost totally different. Because I remember just one scenario. There was this lady during my first time when I was rotating at newborn unit, the NBU. So I don't know, probably Sylvia can correct me. I think the discharge criteria for nurses on children that are born on preterm, I think it's 1800 grams or something, or 2 kg. Yeah, so this lady, when I was reading my first time at NBU, the child was like around 60 grams away. And then like 2-3 weeks later, when I rotated back to the NBU, I still found she was still there, and I saw the pattern. She was missing out on the discharge criteria by around 20 grams the next day. The next time they're measuring weight, which is like at an interval of after skipping one day, was like 40 grams, 10 grams, 20 grams, around there. And so this time when I was getting to weigh the child that was there, this lady told me, please daktari, nakuomba tu tafadhali, mtoto wangu ana miss hizi kilo na grams kidogo sana, nataka tu nifojie because my hospital bill has amounted to over 100,000 and I'm missing out on very small grams inaweza manage kwa nikiwa nyumbani peke yangu bila kuwa hapo hospitali. And so you can tell from the logic part, unaona yenyewe, yeah, but from the professional part you feel like, no, this is not what I'm supposed to be doing, because the criteria that need to be taken. So yeah, the emotional burden was there because I was thinking about this scenario, and apart from that, which was most common, was the patients dying. Yeah, but when it comes to the things that have to be addressed, is the, again, holistic approach. There's a very big gap between UHC and in as far as nutrition is concerned, because if a nurse comes and she sees or he sees your badge as a nutrition, it's done. Your whatever opinion you're going to give probably is not going to be taken. So that is actually one of the gaps that needs to be addressed. Yeah. Thank you.
Thank you so much, Arnold. I think I will read Dr. Reynard's comment on LinkedIn. He says death is a way of life, more so when working in the ICU, NICU, PQ. What you can do is never get attached to a patient, but for me, I'm empathetic, so I get attached, and then you end up crying with the relatives. So that is also one thing I said I don't want to put myself, because even if you try your best not to get attached, and this is a patient you're working with, of course you'll get attached, and when something happens to them, you're going to feel it. And also he says overstepping in one's job description brings about this enmity. This happens more often, but the gap is being bridged pole. So for me, I also agree with him. We are getting there. Like if we're getting positive feedback from you guys and the incoming generation, I can see there's something that is happening that is steering the nutrition cadre in the right direction. So Sharon, you can just tell us briefly the emotional burden, the gaps, and your recommendation as we wind up.
Yeah, okay. My emotional burden definitely came as everyone's. on the part of death. After reviewing a patient, I'm after seeing a patient quite a couple of times, and then almost abruptly they just die. It's used to hit me heavily. But yeah, I had to find a way to cope with it because it used to really make me feel some type of way. So I sat with myself and got to understand that, well, because I find myself, if I've not done my best, I'll actually criticize myself even before anyone criticizes me. So I used to look at it from the point of, have I done the best that I could have? Did I do everything that maybe I could have done? Any, like, within my knowledge, and within that knowledge of mine, did I, like, maybe look up, ask, talk, read, you know any consult, everything like that. So with that brought me some level of, maybe I did what personally I could have done, so that, like, really lifted off that guilt away from me, not like made me feel less sorry or something like that, or less empathetic, but the guilt was lifted away from me from that. Where I think that there's a gap, there's a huge gap, yes, in the holistic handling of patients and holistic management of diseases in hospitals, definitely. There's a very interesting part, uh, case that I met, whereby you know, the patient was renal. They also had cardiac issues. So the cardiologist, sorry, came and reviewed the patient. Then the nutritionist came, reviewed the patient differently, and then the renal team came and reviewed the patient. Now, when the nurse came and looked at maybe all the interventions that were put across, they were all different. Now, she was again calling us differently, asking, as in individually, asking, how do I go forward with this? Because everyone was giving different reviews. Everyone was thinking they're right, because we are all individually managing the same patient. So I think that is a gap there that exists. Also, secondly, in the management of uh, malnutrition, especially in public hospitals, in areas where Millie mentioned that a patient, you can look at a patient and you find that they have economic issues, they cannot even afford the food. Yeah, you know, you're doing some nutrition counseling, but at the same time, you can look at the patient and understand that they're not going to afford the food that you are, recommending. So I think these these two requires that multidisciplinary approach towards it. How do we help people, not just, in the hospital, the now, but how do we make it more sustainable? Because I found that even we are doing medical camps and everything like that, but something that is missing in nutrition is we don't have interventions for the patients. When you're doing the medical camps, we have the pharmacists there, we have drugs, but here we are doing the screening for, as a nutritionist, but then we lack the interventions. We're just there, just, recording numbers of malnourished, malnutritioned kids and adults, but we don't have, like, the interventions, and more so sustainable ones. So I think that is also something that we need to look into. Thank you.
Thank you so much, Sharon, for that. Sylvia, if you're ready, since you're almost winding up your attachment, you can share the emotional burden if you experience any baby passing and how you deal with that and still remain professional, and also the gaps and your recommendation.
Okay, thank you. So my emotional burden is sort of similar to those among the panelists. So, and it's that of balancing between being empathetic and being professional. So I encountered a patient. She was a teen mom. So the father of the baby uh, had denied the baby and herself. So she was crying, telling me all the stories. Now me, I was just there listening, empathizing with her, not knowing what to do. Of course, after listening to the stories, I concluded that it is a psychological issues. It took a mental toll on her, and I referred her to a psychologist. So it's really there's a gap there. It also takes a toll on you. That maybe that I've noticed it is in maybe knowing having hands-on experience. Yes, you will refer her to a psychologist and you'll do all those things that we learn in class. But there's also a gap in having the hands-on experience in how to holistically handling that patient or client and ensuring that he or she receives the care, the real care that he or she needs. So yeah, thank you.
Thank you so much, Sylvia. Lillian, you're our last panelist to talk on the issue. Maybe you can just highlight your recommendation, because you've already passed this or beyond this. Also, your recommendation maybe to the host facility, to people taking students under their wing. What can they do better? How can we be better so that we can train the upcoming generation to actually enjoy practicing nutrition?
What I actually recommend is that one thing, we need to be mentors and we do better than what we got. You know, humans are weird creatures. Some people will want to subject you to pain because they underwent through pain. Others will want to subject you to stress or torture or hardship because they had no one to guide them. We all understand that, yes, maybe it was unfair to some of you. Yes, maybe it was not interesting. There was very limited support. But those students or those interns who come to your facility had nothing to do with it. You are there to mentor them, you're there to guide them, you're there to give them direction and not just confuse and frustrate them. And I appreciate the fact that our current students are actually experiencing positive. That means that people are embracing the fact that we are not in competition. We are not in competition. No student is competing with the professionals. We are there to collaborate and make nutrition great. I think that's a very good aspect and that's a very good feedback, and I appreciate it. And maybe just to help those students who feel like enyewe death is a problem, as Reina has said, death is part of life. Provided you are alive, you're sure. That's the only thing that you're sure of. You will die. And in a clinical setup, when a patient comes in, let's say sometimes someone might be admitted, according to you, they look so good, but of course they might be having other parameters that are failing, so they might die. And I will tell you the words of Dr. Lusweti, who's a pediatrician. She was a pediatrician when I was in Thika, and she oriented us as interns. So she told us, you are here to sympathize. You're not supposed to sympathize with a patient at any time. I know it's hard because you're human and someone will tell you their stories. You'll go to the NBU and mothers will run away from their babies. You'll start feeling sorry for that small tiny baby. You're wondering, why did the mother have to run away from them? You'll go somewhere and then a patient who comes in, they are very young, they are doing well, they have their whole life ahead of them, they will die. Someone will collapse and die even in front of you. But as a human being, you're supposed to sympathize. So if you don't, if you have no, you're supposed to sympathize, but you're supposed to empathize. Sorry, do sympathy itakuleta emotional burden. When you empathize with someone, you're able to step into their shoes without carrying their emotional burden. So yes, you understand that they are human, they have lost a life, someone they love, but now you talk to them with empathy, because now these relatives or the person who has died want you or need you to be there for them. And it's not easy, because sometimes you'll be the only one in that time, or on that particular time when the patient dies, and you'll be able to, what's the doctor like, if you, depending on the rapport that you had built with the relatives of the patient, you might be forced to tell them or talk to them about the death or why the person had to die, So you're supposed to be as professional as you can be, but you make sure that you practice empathy. Be a human being. Before you become a medic, before you become a nutritionist, you're a human being. So you're supposed to accord people's respect. And of course, we are trained to respect life, to make sure that we try as much as we can to preserve it. I know sometimes it might not be easy, because the capacity that we have might not be so simple. Someone wants to sleep. I think we have overgone. It's past her bedtime. So the capacity that we have might not allow you to do so much for the patient, but provided you have done the best, you pray for your patient, you tell God to take control. There's nothing much that you can do. And I know that's why we are pushing for integration of mental health for medical healthcare workers. Because, you can imagine it's not easy watching people die every day, even if you're the strongest person on earth. It's not easy. You're human. Si rahisi ukiona kila siku body bags zinafly zinazunguka, it will get into you at some point. So let's work on taking care of our well-being, try therapy, try anything that will actually get you going. We don't lose into it. But for the professionals who are already practicing, let's be kind. And I am seeing that you have been kind, and we appreciate you. We appreciate the efforts that you're making to make towards ensuring that nutritionists, even the students, the interns, are feeling at home. That is very much appreciated. Let's reduce the small wars that are unnecessary. No one is fighting with. When we collaborate, we make nutrition great. Let's focus on that.
Well said, Lilian. I will not even dispute what you have said. When you collaborate, I think back then there was this mentality of competition among us as nutritionists, but I've seen most of us are rising above it, and we are learning the importance of collaboration. So thank you so much, guys, for taking your time to come and feature on this live. I didn't know how it's going to go, but I feel like it was very interactive, and I've actually enjoyed hosting you guys. So 1 minute, I know you didn't get to do the fun quizzes because of time. I just want you to just say one word as you say goodbye before we end the session. So I think I'll start with Arnold, last word, and then good night, we end the session.
Okay. Probably we should do we should do a podcast for this. Yeah, it has been really great. Yeah, I think this is a very nice platform to share out our ideas. Yeah, so probably my last, I don't call it a one word per se. So probably to those who are going for attachment or are yet to go for attachment, yeah, one thing you should know is that when you go there, expect to learn. Don't go there with the mentality that you're supposed to be there with knowledge. Go there with the mentality that you're going to learn. You're supposed to observe. You're supposed to, I don't know, ask questions. And because practicum or attachment is more of an continuous learning process. So yeah, release the pressure, go there with the mentality of learning. Yeah, that's it. Good night.
Thank you so much, Arnold. Millicent, final words and good night.
Yes. Thank you so much. Final one. Thank you so much for having me. It was a good discussion. I loved every bit of it. Yes. And Arnold, ukiitwa podcast you'll come.
Absolutely.
Perfect. Sawa. Yeah, it was so much fun getting to learn from each of everybody's experiences. And I think, again, sorry to say this, but thank you so much, Charity and Dillian, for suffering so as we don't. Probably, yeah, probably the nice supervisors we've had have been nice because they didn't want it to be like how it was during that time. And yeah, and every student uh, who is listening to this live, I wish you the very best if you go for your field attachment and practicums. Msichukulia vitu kwa roho when the other cadres maybe disagree with you. Ni part of the cons of being in any profession. There are always positives and negatives. But yeah, it was so much fun. Thank you so much, Charity, for having me. Have a good night, everybody.
Thank you, Millicent. Sharon, your final words and good night.
Yeah, thank you very much, Charity, for having me. Thank you, Lillian, for joining us. Millie, Sylvia, and Arnold, for having this discussion with me. Okay, my final word to everyone: remain curious, remain as curious as you can be, embrace the unknown, look into it, venture into it wholesomely, and have a good night, everyone.
Thank you, Sharon. Sylvia, you can say your last words and good night to our audience.
Thank you. I've enjoyed being in the panel and I've enjoyed sharing my thoughts. I hope that what we've shared will encourage someone to know that attachment is very crucial in the coursework at university or even diploma level is very crucial. And as Arnold has said, that you go there with a mentality of learning. Nutrition is dynamic, even the guidelines change, and know that what you learn in class will not always be what you're going to practice in real life situations in the attachment in the hospital. Thank you for having me, and good night.
Thank you, Sylvia. Lillian, finally, one sentence, last word, and good night.
You have been specific. One sentence, last
Yeah,
word,
because
and good
naona
night.
baby girl
So
anataka
maybe
kulala hapo nyuma.
ako sawa. So with me, what I would like to remind us is that the gap that we are really fighting for does not happen overnight. And I thank God, I really like what I see with the students and the new professionals or the young professionals, because it's not just about showing up on social media, it's having the courage, it's having the willingness, it's being human, you know. It's good to have, as Sylvia has said, nutrition is a science and it evolves every other day. So please be up to date, but as well learn how to have those skills that actually make your presence felt. Learn how to communicate, learn how to empathize, learn how to be emotionally intelligent, learn how to react on issues and ignore others, because in a world where we have been taught to react to situations, even our healthcare system is reactive. We tend to react to unnecessary things, and this brings about a bad image when it comes to our profession. This is something that cuts across everyone, not just the young professionals, not just the students. So yes, we need, of course, we would have done better when we were interns and students, but you see the hostility that we got was, we could not ignore being reactive. So if you don't get it, do not create hostile conditions. And even if you did, please learn that these students had nothing to do with it. It was the system, it was maybe the government, it was maybe the lack of a channel to express your frustrations, but it was not the student. And then as we move forward, I've seen a comment by Eunice asking about if we are taught about grief. We are not. That's the unfortunate bit. But you see, when you're going for practicum and attachment, they expect you to learn for yourself, which is not something that is interesting, because you're supposed to be taught how to, of course, no one can really show you how to handle grief. That's a personal reaction, that's a personal thing, because some people endure pain differently. Like, I know I don't have a very high pain tolerance, so spendi uchungu, but resilience and emotional strength, I think I have it. I can really move past hard things that people would actually expect me to scramble. But you see, even death, even with such, death still has that pinch. And as Rachel has said, it's not easy to just see your patients dying. So I think maybe we need to look for ways. Of course, the best way would actually to integrate mental health care for healthcare workers as a in-service. Not training, we don't want to train them on mental health. We want now to offer mental health to the healthcare professionals. Now, whereby they undergo not just the team building activities for physical activity. You see, the way there has been integration of physical wellness or community continuous learning systems and such. Now we integrate mental health care for these healthcare professionals, because at the end of the day, they are humans, and they are the ones for you to take care of someone, you have to be okay. So let's push for that. I've seen Geraldine doing that, and I hope that the adoption and the integration and the implementation of the mental health policy is also taken into effect in the health sector, because healthcare workers are struggling. You have all seen sorry about that. You have all seen the levels of alcoholism and drug use and abuse in this sector. It's serious. And people usually wonder, someone will ask you, why is a doctor drinking? Why is a doctor smoking? Why is a nutritionist drinking? Why is a nurse smoking? But people are trying to cope. People are trying to find coping strategies because of the hours, because of the shifts, and maybe the mediocre pay, as someone has highlighted. So all these are some of the things that we need to really advocate and keep talking about, so that we can make sure that we make our profession great. So I hope that moving forward, we'll not have these unnecessary stupid wars. They're not stupid. Others are very important, but ya kusema ati, oh, we are fighting against diploma and degrees. No, let's learn how to work together. Kenya, as a nutritionist, Kenya does see enough. If you are to be absorbed as per the guidelines and the recommendations, we are not even enough. So let's just make sure that we maintain our standards, because quality is important. And if you are not maintaining that by allowing entry through certificates, normal, it will be something that anyone can just wake up and decide they want to do. And let's make nutrition great. We have that opportunity to make nutrition great, because it has never been great in this country. It has just been like any other thing. Let's make it known. Let's make it visible. Let's make it core. It is core on paper. It is core on policies. It is core on acts and such. But when it comes to implementation, when it comes to integration, when it comes to financing, budgeting, it is really limited. So let's be visible. Let's talk about nutrition. Let's practice it with so much pride, and let's learn as much as we can when you go for our attachment. If you're a student listening, all the best as you go for your practicum, for your practicals, for your trials, whatever you're going through. Remember that it is a phase and it will come to pass. Kama ni mimi nimekaa like in the other side as a professional, anyone will. So just be resilient, be patient, learn as much as you can from your supervisors. Ukienda place and you feel like people are not willing to offer mentorship, look for your own mentors, but make sure that they align with what you're doing. Look for mentors, because again, someone who has walked the journey that you are now trying to walk is in a better position to help you than someone who has not. You might find that someone just went to school, maybe they did one thing and then they just got employed because there was nothing else to do. So they don't know what you're dealing with. But we thank God the generation or the professional that we have currently have gone through the internship, they have gone through the attachment, they've gone through the practicals and all that. So reach out for mentorship. Don't leak asses. Ukilika asses utatumika vibaya. So make sure that you maintain professionalism at all times, healthy boundaries, safe spaces, and take care of yourself. In all that you do, see cheesy, and try as much as you can to be physically, mentally, and emotionally okay so that you can deliver your best when you go to practice. And that is it from me. It was a very insightful conversation. Imenirudisha mbali sana. And yeah, do not be reactive. You have no, like from the feedback that you have gotten, you have no right to be, you have no reason to be reactive. You have the union. You can write to us. We will react on your behalf. Usichome. Sawa. We will write and react on your behalf. So the SG is there. He listens. Just write at a react, and he will react on your behalf because you are his people and you're his children. Asanteni sana and good night.
Thank you so much, Lillian, for those powerful words. This has been a very powerful session. When I was coming up with it, I was planning. I didn't think this day will come, but I'm so grateful to George, the president of the Student Association. He really helped me with the names and everyone you see on this screen. So thank you so much for bridging that gap between the working professionals and the students. And if you're a student and you're watching, please purpose to join the association. It has a lot of benefits. I wish sisi tukikuwa huko tungekuwa tunajua hizo vitu, but yeah, so you are in a position and the association is on social media. You're able to contact them, get in touch with them. Universities have associations too. So purpose to join, you'll be able to learn a lot and become better. So to my guests, thank you so much for taking your time to come and chat and talk about your experiences. It has really been enlightening, and I'm very happy that the incoming generations are reaping the fruits of us suffering back then, and now nutrition is starting to pick its pace, and most of the healthcare cadres, if you go to a good hospital, they have embraced nutrition and they have integrated it into the healthcare system of the hospital, so you will not have a hard time. I wish they will rudisha the internship, because you'll get to have 1 year of experience. You'll get to know what you want to do and what you do not want to do. Because for me, my internship was my aha moment. And that is when I knew I wanted to do what I'm doing right now. So thank you for joining me in the comments. It was very interactive in the private chat on LinkedIn. Thank you so much. And I'll purpose to organize another session, so be on the lookout. This episode will be on my LinkedIn page and also on my YouTube channel. If you have not watched from the beginning, you go and replay and watch and get to enjoy what we have enjoyed these 2 hours. So from me, Charity, from Charity Safe Haven, to you guys, good night and bye.
Good night.
Good night.